So I want to talk to you guys today about weaning from mechanical ventilation. So in our COVID ICU patients, we've seen some very difficult to wean patients. It's brought up some discussion points about when we know they're ready to try to extubate and what strategies we can do to try and get them there faster. So I just wanted to go over a pretty quick review of some of the key papers that are important when you're deciding on how to wean your patient from the ventilator. So we'll talk about how we select who we're going to wean, how we're going to wean that ventilator support, when is a good time to extubate, and what objective data we can use. And then we'll talk briefly about the role of early tracheostomy, although obviously none of these papers were done in COVID-19 patients. So I think one of the key things to realize is that notoriously, we physicians in the ICU are not great at extubating appropriately. You'll notice there that accidental extubation happens in 16% of patients, and almost half of those who self-extubate don't need re-intubating, which tends to imply that we're probably not extubating soon enough. And then, if you look at the top bullet point, there's actually pretty good data that almost, half of the time a patient spends on a ventilator is actually weaning. So what can we do to make this process faster and liberate these patients from the ventilator sooner is an ongoing area of research. And then also just keep in mind that, we all hope that when we extubate a patient, there's no reintubation, but really across good quality ICUs, the rate of reintubation is almost 10 to 15%. And that's probably, indicates that you're trying to extubate aggressively. So we're not expecting to be perfect. So I draw your attention to this. This was the last major set of guidelines for weaning and discontinuing the ventilator. And you'll notice it came from 2001, published in Chest. And so far this has not been updated. So we're going back a ways. However, there's still some important points to be made. So they recommend a set of objective measurements for who can be weaned. So you can see there, you're looking for adequate oxygenation, which however you're measuring it is really, their criteria is not that stringent. So a P to F ratio of 150 still puts you in a pretty severely hypoxemic category, but the data suggests that it's appropriate to try to wean that patient. You want a hemodynamically stable patient. You want someone who's not actively febrile, although this is an ongoing area of interest in COVID because these patients may have fevers for a very long time. You obviously don't want a respiratory acidosis because that's implying that the patient, even on the ventilator, is unable to ventilate adequately. They suggest an adequate hemoglobin, although I think the evidence behind that is pretty weak. And then you need a mental status, right? It's going to be a lot harder for someone to protect their airway, clear secretions, take deep breaths, and cough if their mental status is significantly depressed. So they suggest a GCS of 13. I know a lot of neurointensivists really don't have the luxury of having that GCS in their patients, so their data suggests otherwise. But obviously, the more awake the patient is, the more likely they are to do well. And then you don't want any metabolic derangements, especially like a severe metabolic acidosis that could influence their work of breathing and make it harder for them to compensate without the support of a ventilator. And then, obviously you're looking to see that whatever it was that made them require the ventilator has now improved enough that you think it's going to be possible to wean them. So there's a bunch of parameters one can check when you're looking to see if a patient is strong enough, ready enough to breathe on their own. So this is a list of parameters that are commonly used that you might hear respiratory therapists mentioning. So, some of them are listed there and you'll be familiar with it, like a patient's minute ventilation. So obviously, if the patient has an extremely high minute ventilation, that's going to be hard to compensate when they don't have the support of a ventilator. NIF is a negative inspiratory force, and the sort of suggested values for that are minus 20 to minus 30 centimeters of water. But as you can see, the likelihood ratio there is not great. You can see with the others as well, there's more indications of, just how much pressure a patient can generate as an indication of strength. The CROP score is not widely used anymore. But then going further down, respiratory rate and tidal volumes have been used together to calculate a rapid shallow breathing index. So kind of putting those two together, that actually has some more evidence behind it. So if you want to calculate someone's rapid shallow breathing index, just so I'm clear about this, because I find it one of the most helpful parameters, you take the respiratory rate divided by their tidal volume in liters. So if you think about what yours might be, if you're sitting on the couch, let's say relaxing, you have a respiratory rate of 10. And for ease of calculation, let's say your tidal volumes are half a liter. So 10 divided by 0.5, your RSBI would be 20. Now, up to 120 has been shown to be likely to be successful after being extubated. So you can really imagine if, as you go around rounding on your patients on their pressure support trials, calculating this value. Some ventilators actually do it for you. Our servos, I don't believe, do, but certainly you can calculate it. So if someone's breathing, 30 times a minute with tidal volumes of 300, that, gives them an RSBI of about 100, if I'm doing my math correctly. So an indication that their breathing is rapid and shallow. And certainly, looking at that is a good way of sort of evaluating their respiratory function, and several more recent trials have looked at that, and I think it is probably one of the more helpful parameters we check. So all these things that have been looked into, none alone is a great predictor of whether a patient can be extubated or not, but put together gives you some more data to help you decide on who's appropriate. So the original paper, I believe to be the original paper that really looked at how you wean a patient, came in the New England Journal back in the 90s here. And this was done in Spain, a great collaborative effort where they looked at over 500 patients that were medical and surgical in their underlying disease process. And this was their criteria for deciding whether they were ready to wean. So they wanted a P to F ratio of greater than 200. On a PEEP of 5. They wanted afebrile patients. Hemoglobin of 10, I think, reflects, kind of ICU practice at the time. We know now that we're a little bit more restrictive with our transfusion strategy. They wanted no vasopressors or sedation, and the patients they used had been on the ventilator for an average of 7 days. So what they did is they did a spontaneous breathing trial, which you've all seen the respiratory therapists do, and we'll talk a little bit more about different ways you can do that, but one where you take away the mandatory ventilation that the patient's receiving in one way or another and see what happens. And so this was how they decided who failed that spontaneous breathing trial. So if they were tachypnic, desaturated below 90, if their heart rate changed significantly, they were hyper or hypotensive, or just looked terribly anxious or agitated, or if they really thought they couldn't clear their secretions, then they were considered to have failed their spontaneous breathing trial, and they were randomized to one of 4 groups to help them wean their ventilation. So I made this table to kind of show you the 4 groups they randomized to. So SIMV was used in one of them, where how they set it was they set a respiratory rate for the mandatory breaths of 10, and then they were given CPAP only on the unassisted breaths. And every day, or twice a day actually, you can see there, they decreased that respiratory rate by 1. And then once they were able to get the mandatory rate down to less than 5, the patient was extubated. Then there was a pressure support group where they gave whatever pressure support the patient needed to not be tachypnic. And then they, every day or twice a day, they would decrease that inspiratory pressure slightly. And so more of a gradual wean with a spontaneous mode of respiration. And then they extubated when the patient was able to tolerate pressure support 5/5 for greater than 2 hours. Then they had the group that did an intermittent spontaneous breathing trial, where either they would use a T-piece, which is not an option on our COVID patients, and you may not have seen it, but really you literally disconnect the patient from the ventilator and connect them to humidified oxygen, so they have no support whatsoever. Or they gave them CPAP of 5 through their endotracheal tube, and they would let them try TPs for 2 hours. And if they failed with the criteria that were mentioned before, then they'd put them back on assist control and try again, whenever they felt was appropriate. And then they had the daily SBT group, which was the same protocol, but they did not try it more than once a day to do the TPs. So what they found was that a once daily trial of spontaneous breathing was superior to both SIMV and pressure support in weaning patients off of mechanical ventilation. The once daily SBT patients were extubated, I think, 3 times more quickly than the SIMV patients and 2 times more quickly than the pressure support patients. And there's a lot of hypotheses behind this, especially with SIMV. It's thought that, the different loading forces on the diaphragm, given, the variation between a mandatory breath and a pressure support breath, might lead to really not helping the diaphragm gain strength and also not fully supporting the patient, so really kind of lessening the advantage of both methods. The reason for pressure support not being better is less clear. Obviously, with pressure support being a spontaneous mode of ventilation, you really do not have control over the patient's respiratory cycle at all. So it's a very comfortable mode for the patient, but it does mean that typically the mean airway pressure is lower in pressure support than it is in a assist control mode of ventilation. So it's possible that you're encouraging de-recruitment over time, even though you're giving, seemingly adequate inspiratory pressure support for that patient's tidal volumes. And then importantly, you see there that they showed that the intermittent trials of spontaneous breathing were no different. So when you're thinking of kind of pooling your ICU resources, they didn't show any benefit to trying to do this more frequently than once a day. Keep in mind that this is, a relatively small pool of patients. Even though there were 500 in the study, only, I think it was 130 we looked at, failed their initial SBT and got randomized. So in each of these arms is a very few number of patients. However, I do think it was an important data to consider. So going back to the guidelines that heavily relied on this paper to advise them, this is how they recommend you objectively evaluate your patient on whether they have passed a spontaneous breathing trial. So this is, after a period of time, you want to show that they're still maintaining their oxygen. And again, they're really not asking for greatness here. They want a PaO2 greater than 50 to 60, SATs of 85 to 90%, pH greater than 7.32, with no evidence of change there, showing that the patient might be tiring out. And then the other things that we mentioned: hemodynamic stability, stable ventilatory status, a good mental status, and subjective evaluation of the patient's work of breathing. A more up-to-date paper, this was done, I think, 2019 in JAMA, where they looked at how you do a spontaneous breathing trial, because it really hadn't been revisited in a long time. And a lot of people have different protocols on how they conduct this, very institution dependent. This group looked at pressure support versus TPs for spontaneous trials. And I just want to emphasize again that you cannot suggest a TPs trial in a COVID patient. That would be a huge exposure risk. But carrying this forward to when we have other patients who are difficult to wean, this is a good piece of data to consider. So this was a multi-center randomized controlled trial in Spain, 1,100 adult ICU patients, both medical and surgical. And to qualify, they really only had to be ventilated for more than 24 hours. So not a long time. Some of those patients might not be considered, difficult weaning patients anyway. And then the criteria they used are listed there, the same things that were used before. So people that you would think are appropriate to try a spontaneous breathing trial with. So then they randomized them to either a TPs for 2 hours or a pressure support trial. But importantly, the pressure support trial was done with 8 centimeters of water as an inspiratory pressure and 0 PEEP, which is an interesting interesting kind of practice that I myself have never tried. More commonly, I see 5/5, meaning 5 of inspiratory pressure added to 5 of your PEEP. And then this is how they described failure. So change in mental status, tachypnea, desaturations less than 90% with an FiO2 greater than 50. So again, really not expecting greatness on oxygenation. And then hemodynamics, also important. So their primary outcome was successful extubation, and they defined that as someone who is still free of mechanical ventilation 72 hours after they were extubated. And they looked at secondary outcomes too, like rate of reintubation, ICU and hospital length of stay, and mortality. So their patients probably look a little different than ours do, but we're a sick ICU population. So their Apache 2 score is 16. Apache 2 scores were used to kind of estimate severity of illness in the ICU, and that's pretty representative. I don't think that's far off of what we might see ourselves. They're older patients. You can see median age there of 65, and mostly medical, some emergency surgery patients in there. But importantly, the length of mechanical ventilation before they attempted SBT was a median of 4 days. So I think that's a pretty good population. And then they did not specify how clinicians chose whether to use non-invasive like BiPAP or high-flow nasal cannula after extubation. So that was done at discretion of the clinicians who were treating, and you can see that it was a little bit different between the groups there. So looking at the data that they have, what you'll see is the successful extubation was significantly more likely in the group that was given the pressure support spontaneous breathing trial versus the patients who received a 2-hour TPEACE trial. So you can kind of look into that and kind of suppose why you think that is. I personally think it's very, very hard to ask patients who've been in any kind of respiratory failure to do a TPEACE trial, that a 2-hour period with no ventilatory support, breathing through an endotracheal tube is uncomfortable. It's a high level of airway resistance that they have to compensate for by already weakened muscles. And probably you're going to say that more are failing that spontaneous breathing trial when they probably would breathe more comfortably and more easily without that tube being in place. So I want to talk briefly about the role of early tracheostomy for ICU patients when you're weaning from the ventilator. This literature is not based on COVID patients, which we're still trying to, evaluate the role of tracheostomy in those patients particularly. But overall, we have a nice Cochrane review that was updated in 2018, looking at, all of the evidence supporting early versus late tracheostomy in these patients. What they found overall, just as a very brief overview, is that in the highest quality studies that they looked at, there really was a significant difference in mortality when patients underwent an early tracheostomy. And they defined early as anywhere from day 2 to 10 of mechanical ventilation, and they defined late as anything greater than day 10. As you can see, some of the individual studies really themselves didn't show a benefit, but the pooled data they felt really did. They looked at other outcomes as well, in particular like duration of mechanical ventilation and ICU length of stay, and the studies were too heterogeneous to be pooled, so they couldn't comment on a significant difference in either duration of mechanical ventilation or ICU length of stay or hospital length of stay. Individual studies, however, have shown an improvement with early tracheostomy in those measures. And I think, conceptually it makes sense if the patient is able to be awake, not sedated, and participating in, aggressive physical therapy and rehabilitation, that patient might do better than one who's needed to be administered sedation and be more sedentary for greater than 10 days. So overall, I think most clinicians will consider tracheostomy if they feel the patient's going to be ventilated beyond a week. It's certainly a conversation to have. In COVID patients, we really don't know, and obviously it's an exposure risk for people performing the procedure and assisting with the procedure. So it'll be certainly an area that will be interesting to see how clinicians around the world have handled this. Here are some references for you. I emailed you guys 3 articles, the Esteban article from 1995, which is an interesting read, just so you can see how they set up such a cool trial. The CHEST guidelines are just for reference, really. You can read their kind of summary statements because they're pretty vague. And then the most recent trial I emailed you is that last one by Subira in JAMA, and I think that's the most contemporary and relevant to our practice. So I'll be happy to discuss when I am next on service with you guys. All right, hope you're staying healthy. Bye.